Okay.
So good afternoon, everyone. I hope you're well, and thank you for joining today's webinar session. As many of you know, my name is Kamal. I'm the Relationship Manager here at HCA Healthcare UK, and I'm delighted to introduce today's speaker, Mr. Mark Phillips, who'll be providing a talk or a hand update. Mr. Phillips is a consultant orthopaedic surgeon with many years' experience in adult hand and wrist surgery, as well as trauma surgery, elbow conditions, and complex injury surgery. He has particular interest in performance-related conditions in musicians and sees patients at London Bridge Hospital as well as 31 on Broad Street. Just wanted to touch on about our service or orthopedic and spinal service at HCA. So we pride ourselves on treating individuals and not cases. Number one in London for private orthopedic care. We've pretty much seen it all from sports injuries to complex spinal conditions. And all of our services are underpinned by an ITU and complex medical capabilities for facilities of all ages, including children, which is at the Portland Hospital. All appointments to see a consultant can be confirmed within 24 hours. And if you need a scan, this can be arranged on the same day. At the bottom of the screen there, you'll see a number for patients to call, whether it be self-pay or if they have private medical insurance, and they also can arrange imaging via that number as well. So if you do have any questions or like further information, feel free to get in touch and I can provide that. So before I pass it over to Mr. Phillips, we just have a couple of housekeeping points. As you see, the session has been recorded and will be shared with you following the webinar. And because of the group that we have today, it is an open forum, so please do ask your questions or you can leave them towards the end for the Q&A. But without further ado, I'll pass it over to Mr. Phillips. I'm just going to share his slides. Just give 1 moment. Yours, Mark.
Thank you very much, Kamal. Yes, so I'm a hand and wrist surgeon. I was a general orthopedic surgeon when I started as a consultant in 2001. I worked at King's for 15 years, and then I had enough of apologizing to everybody and decided I just wanted to work in the private sector, and I've done that since 2015. I gradually became an upper limb surgeon and then dropped shoulder about 5 years ago, and I inherited around that time a very busy musician's hand practice of Ian Winspur and John White, and I'm a keen amateur trumpet player myself, and so they both were happy to hand their practices over to me. So I'd say just a little over half my patients now are musicians, and I see other people in the city. Mainly it's office workers, of course, which are presumably the same people that you see in occupational health, etc. Yeah, if I work at Old Broad Street mostly on Wednesdays and Thursdays, and other places on Mondays and Tuesdays. I do Zooms on Fridays now, which is a new way of working, which I'll come to talk about later on, which I've really enjoyed. Benefits of lockdown, and I'm pretty much back up to as busy as I was before lockdown, but it's been a funny sort of few years. So I'm going to tell you what my practice looks like, run through some of the common conditions, and then we have some time for some questions at the end. I'd like, if you have some questions, that'd be nice. It would make it a bit more interactive. And if you want to stop me at any point, I'd be happy to take questions during the talk. So come on, unfortunately I don't have control. So if you put the next slide up, come on, thank you. Yes, so this is the group of us at London Sports Orthopaedics. We were bigger. A lot of people left in lockdown because the service charge was expensive and people didn't have a practice to pay it with. So so people left. But this is who we have now. We've got 2 hand and wrist surgeons, me and Mr. Zachary. We've got 2 upper limb surgeons. Verona's on maternity leave at the moment, and Dowd is our shoulder surgeon mainly. We've got Simon Paul as a rheumatologist and sports physician, and then we've got probably people that you may well have known already. Our founding partner, Ian McDermott, who's a knee surgeon, and Henry Atkinson appears twice because he does hip and knee and foot and ankle. So he's a lower limb specialist like I was until a few years ago. Peter Hill just does knees. Ari Ghassemi does foot and ankle, as does Suresh Chandrasekhar, and that's where you can find us on Old Broad Street, just around the corner. So yeah, next slide, please. So what do I see in the city? Well, it's like the child catcher has been round from Chitty Chitty Bang Bang. There are no children in the city, of course. They're banned. And of course, we can't see any children. I can't see any children in any of the clinics I work in. I do see some people between 16 and 18 on Zoom, but generally it's a child-free zone. So But it is a very young demographic of patients, and as a result of that, I see an odd kind of population of people compared to other hand surgeons around the country where all the old people live in provincial Britain. So, and so presumably like you working in cities, in occupational health, etc., you will see a lot of people very much into downward dogs, planks, burpees, landing on their hands, vaulting and springing on their hands. So their hands are being treated like feet these days. The gym, of course, has now become a new dating forum. And so that's where all the young people hang out after work, and after doing long hours of work to pay for their expensive mortgages, they then go to the gym. So that's makes the hands very busy, tired, and good for business for me and you. So I also then see a lot of musicians, and of course their hands are very busy too. So let's get on to the next slide. So this is what I'm going to run through, the common things that you and I would see related to the hand, wrist and forearm, and I'd be happy to talk about tennis elbow, golfer's elbow, if anyone's interested in that as well, and cubital tunnel syndrome. But those are outside what I put on the slide. It's mostly tendinitis that I see, and I don't suppose that'd be any surprise to you for people with busy hands. And I'm happy to talk about work-related upper limb disorder. That's a very broad group, and for me it's about working out which tendons are causing the trouble. Sometimes it's an overuse syndrome, it's a more diffuse phenomenon, and sometimes it's a very precise tendinitis, and sometimes it's in between the two. So we're currently seeing people from snow sports again for the first time in 3 years. People haven't really been away, they've been missing it, and they're currently falling over in large numbers. And actually, we've also got a similar sort of mechanism of injury now from e-bikes in the city. E-bikes and e-scooters. They're a very good way of injuring your hands, because tarmac is a lot harder than snow and ice. In fact, I was thinking of putting a little sort of, going around London, put little stickers for London Sports Orthopedics on the e-scooters, which people use after midnight. So snow sports, basically, I'm going to run through how you commonly injure your hand and wrist in snow sports, and then going to go through dorsal wrist impingement, which is this condition where when people put their hands on the ground, they get impingement, which is pinching at the soft tissues of the back of the wrist. I'm going to talk about ganglions a little bit. I'm going to talk about carpal tunnel syndrome, trigger finger decurvins. They're all types of tenosynovitis, essentially. Thumb-based arthritis is the commonest type of arthritis in the hand. I'm going to talk about adverse neural tension, and I'm going to develop a little bit about what I see with musicians as well. So I'll deal with each one of those in turn. So come on, next slide, please. So musicians and office workers, what do they have in common? What have I discovered that they have in common? Many people in an office work in a fetal position for long hours and don't take a break. And musicians do the same thing. I'm a trumpet player, so obviously I do hours and hours of practice like that. And then pianists are the same, and violinists and flautists, they're all sort of hunched up in that sort of position. So the landing swan of that stretched out arms and the big expansive posture is the opposite of what you tend to do in the fetal position. So taking breaks and regular stretches you'll be familiar with, and I think that's important in music and in office workers too. All the postural issues that you'll be familiar with, and long hours of work. Some city workers, when they tell me they have a busy day, I say, what do you mean by that? Well, they say 13, 14 hours at the office for some people, crazy place to work. And people playing guitar, sometimes 8 hours a day, very common. Next slide, please, come on. So then snow sports. What do they have? What do they commonly do? So there's lots of different ways you can break yourself when you fall over when you're going on a skiing holiday or a snowboarding holiday. And in fact, if you look at the statistics for how likely you are to see a doctor on your return from your skiing or winter sports holiday, it's actually 1 in 100. People will see an orthopedic surgeon after a week of skiing holiday. If you think that's probably more than you imagined, just think about if you've ever been on skiing holiday, whether there's anybody in a sling or a splint or walking on crutches by the end of your week in your holiday resort. In the restaurant where there are about 100 people having dinner, you'll find that there's usually one by the end of the week on every single holiday. and on the plane there'll be 2 people on the plane on the way back in a sling or a splint of some sort. And that's why you see walking around the city right now, people who are normally fit and well look like sporty young people walking around with slings and splints and crutches. So it's good for business, it's very dangerous holiday. The commonest one, of course, is undercollateral ligament, skier's thumb. You can rupture the ligament on this side of the thumb very easily when skiing. I tend to hold the poles without putting my hand through the strap, but then, of course, if you drop your pole, it comes away and you have to go back up the mountain to get it, and you have to be careful to not drop it in an inconvenient spot. But I find the strap is quite dangerous, so don't do that. I repair some of them. Some of them repair themselves. We do ultrasound, MRI scan to check whether they've got a thing called a stena lesion, whether the ligament is torn apart and is either side of the adductor tendon and therefore is not likely to heal, and they go on to become unstable. You can repair them late. It's not an urgent operation, and I often have that discussion with them about whether they should have it repaired now or whether they should wait and see whether it's stable or not in the long term when it's all settled down. I see a few distal radial fractures. If you go on a skiing holiday, you're most likely to tear your cruciate ligament, but a quarter of all injuries from skiing are hand and wrist injuries. If you go snowboarding, half the injuries will be hand and wrist. There's a lot of sore bottoms from landing on the bottom, but then if you go the other way and fall forward, you'll get a wrist fracture. If you go ice skating, you're 90% likely to injure your hand and wrist for obvious reasons. And I get quite a lot of people who just come back from holiday, said they weren't even skiing. They were just walking in their ski boots or on their après ski shoes and slipped in the resort on the ice in the resort. And that's probably more common than any other dramatic skiing accident, actually. Right, that's all I was going to say about snow sports. Actually, we can come back to it if there's anything else you want to say about that. So come on the next slide, please. Now, this is really common in the city. Now, when I mention it, you'll think, I think I've seen some patients with this. It's not talked about very much in hand circles because around the country, most people aren't like the people we look after in the city. So most people don't do a lot of open palm weight bearing exercise. Because if they're like my mum and they live in South Wales, they would never dream of doing anything as active as this. But if you're a young, hyperdynamic young person and you spend a lot of hours in the office working, and then you want to go to the gym, this is what people seem to want to do these days. And it causes edema in the dorsal wrist capsule, and you can see that on MRI scan. And sometimes you see a small occult ganglion, which you can't see clinically, and it causes pinching at the back of the wrist. And you might not believe it, but I do see 1 or 2 new patients with this every week. It's absurdly common. The good news is it's very treatable. Sometimes it's been bothering people for a few months, sometimes it's been bothering people for years, and a single steroid injection is really good at reducing the inflammation in the dorsal wrist capsule and stopping that vicious cycle of repeated pinching of that soft tissue. So when I talk to physios about this, they say, yeah, I'm treating patients for a knee problem, but they can't walk on their crutches because they can't take the weight on the crutches because they've got this wrist pain. Would you see them for that? I say, yeah, please, send them along. And a single steroid injection is really very powerful way of dealing with that. And that's just a quick fix. That's the cheap and dirty way of fixing it. A better way of treating it is trying to make sure that people don't hyperextend. If you look at that person doing the, I think it's called a crow, when you stand on your hands and you lift your legs in the air, that's hyperextending the wrists, and that's going beyond 90 degrees, and that's where the damage really happens. And so if people have got strong wrist flexors, when they hit a wall or they land on their hands in a burpee, or they're playing squash and they've got the wall, or they're doing a handoff in rugby, if they've got strong flexors on this side, they'll brace their wrist really quickly and powerfully, and if their proprioception is good, they'll secure their wrist. If they've done lots of stability training on their wrist, like physio can advise them, then they'll not injure their wrists as easily as somebody who's got a weak wrist and it allows overextension to happen too easily. So hand therapists, really important there. So they're specialized physiotherapists that do a lot of work with hands and hand surgeons. And they do a 3-year diploma, and I use a lot of the hand therapists in and around London. HCA has a great department at the Shard, Greg Sullivan and David Baker. So yeah, that's all about wrist stability training. We can do some taping around the wrist. That's K-taping. Sport tape is quite useful to prevent people from overextending or just reminding themselves when they're overextending their wrists. And it's a great way to stop them in the long term getting the condition again. When the steroids wear off at around 6 to 8 weeks, many of the patients don't have recurrence. More than half, I would say, never see me again. Possibly because they just didn't enjoy the experience of meeting me, but more commonly, I think, is they're better and they come back for other things and say, yes, that was good, but now I've got this other problem. Sometimes it's not just a dorsal capsulitis or a small ganglion. Sometimes it's fourth extensor compartment tenosynovitis. And if you look at that MRI scan, you can see the tendons at the back of the wrist, and there are several different compartments for tendons, and each one of these extensor compartments can become painful. I see patients with central dorsal impingement. I see patients with radial impingement on the dorsal-radial aspect. I see patients with dorso-ulnar impingement as well, and that's quite common when people are lifting themselves out of a chair on the arm of the chair like that. That will cause ulnar loading of the side of the wrist. Central loading is what you do with a broad-based push-up, and then you get with a if you go even further with your push-up, you'll get radial-sided loading of the wrist. So yeah, that's a really common and not often talked about problem, but it's very common in the city, and people that spend hours at a desk and then go off and hit it hard in the gym. I'll come back to that if you've got more questions later. Next slide, please. Yeah. Now, a lot of NHS commissioning groups have decided that ganglions don't need surgery. Do they need surgery? Well, if you leave them alone, about 50% will disappear over a 5-year follow-up. So that's what research shows. If you aspirate them, or aspirate them and inject some steroids, or you puncture them several times, peppering them with a needle under ultrasound guidance or just directly, they recur very commonly. So 80 or 90% will recur within weeks after that procedure. They're often smaller and more comfortable. It reassures the patient that it was just a ganglion and wasn't a tumor. It tells the doctor that it wasn't a tumor as well, of course. It saves you on an ultrasound if you just do it directly. Ultrasound is quite expensive, of course. If you inject some steroids, that can sometimes reduce the edema around the lesion, and that will reduce the discomfort around it. So often ganglions are painful. And if you surgically excise ganglions, you've got a 20% recurrence rate at 5 years nationally. So that's quite high. Some ganglions recur more often than others. Ganglions around the wrist, that's about right, 20% at 5 years. Mucus cysts at the tip of the finger, I think probably a little higher. So mucus cysts that come at the DIP joint here, they're probably 30 or 40% over 5 years, whereas those little cysts that you sometimes feel, little sort of half-centimeter pearl ganglions, as they're called, that come from the first annular pulley where you get trigger finger. You get a little ganglion forming here. You can feel them, you can't really see them. Those are really good. If you puncture those, they rarely come back. And if you surgically excise them, they very rarely come back. So different ganglions have different recurrence rates, but surgical excision is the most common way of eradicating it once and for all. And as I say, so leave alone 50%, aspirate, inject, 90% recurrence, excise, 80% success rate. And they only need surgery if they're painful. Some patients try to argue that their cosmetically upsetting ganglion is justifiable on their insurance. But I do have to say that they're painful for them to be justified on insurance. And actually, it's not sensible doing surgery for people who've got that, because cosmetically, it doesn't look any better to have a scar. I think some people think it does. And then there's all the risks, of course, of stiffness, infection, nerve injury, tethering, recurrence. By the time you've run through that, generally people are put off having surgery for cosmesis. Next. Yeah, these three I've bunched together. These are all essentially tendonitis problems. So carpal tunnel syndrome is caused by all of the 9 tendons in your wrist, that's 2 to each finger and 1 to your thumb, getting swollen and competing for space with your median nerve in the carpal tunnel. So swollen tendons from busy typing, a very common problem. Trigger finger is when you have one swollen tendon, often comes with carpal tunnel syndrome, and then one finger will jam. We've got 3 grades of trigger finger, actually 4. Trigger finger grade 1 is click, click, click. Grade 2 is clicks, but you need your other hand to pull it out. Grade 3 is when it gets stuck in flexion and neither the doctor or the patient can get it to come out anymore. And grade 4 is a strange one. It's when it's stuck in extension and they're too frightened to bring it down, because if it locks, they know they won't get it back again. And that's when the nodule is just on the far side of the first pulley in the hand. The nodule is just a thickening of the tendon as it passes through that pulley system. And I see a lot of that in musicians, by the way, but office workers as well, of course. But musicians get a lot of trigger finger. And of course, they freak out just at the slightest sign of it triggering, because they don't want their finger to be delayed in its movement at all. De Quervain's is mostly in young mothers who pick up small children. And I'm increasingly seeing it in hands-on fathers as a badge of honor, picking up their children. I also see it in grandparents or nursery workers, and I've also seen it in a lady who looked after small puppies on a puppy farm. And I think it's basically picking up things like this. But I think legal folders, A4 ring binders, which are less common now, or bricks, bricklayers and carpenters putting down a 4x3 would be doing that wide-spreading gripping gesture, which is what seems to bring on de Quervain's tenosynovitis. And there are lots of instruments playing harp, for example, or double bass, which involves that gripping gesture as well. And that would be likely to cause that piano octaves. That tends to bring on de Quervain's tenosynovitis. Easily diagnosed, fantastic test, Finkelstein's test. Put your thumb inside your fingers like that, bring your fingers over the top and do that. And you can do it on one hand compared to the other. Brilliant test. It's so specific for the condition. Finkelstein's test, you can check that out. And then it's tender over the first extensor compartment to the thumb here, which has got 2 tendons in it. So how do we treat these? Well, lovely big study in the States, 2016, published in the journal Hand Surgery, tens of thousands of patients on a massive audit, came out with these, with some really good figures for me, which are consistent with my own practice. Basically, if somebody has positive nerve conduction studies for carpal tunnel syndrome, 90% of those patients have had an operation within 3 years. It's a very effective operation. Most people have recurrence after they've had a steroid injection. Most people find that once they've got as far as having positive nerve conduction studies and having a steroid injection, it's causing enough of a nuisance that eventually they decide to have an operation. Of the patients who have an operation, 90% are happy, and the 10% who are unhappy is because it was the wrong diagnosis, or they are unhappy about the tenderness around the scar, weakness of grip strength, or their nerve was too badly injured to recover. And that tends to be people in their 80s and 90s who've had it for 20 years and have done nothing about it. And the nerve damage is quite bad. On the nerve conduction studies, you often find that they have the very severest type with muscle wasting here, thin eminence wasting, and those don't recover well after surgery. But most people have a prompt recovery and are often feeling symptom improvement within days. But you do have to warn people, particularly musicians, that it might take a long time to feel strong again. I feel carpenters, builders, probably talking about 6 weeks or so before they'd be back to decent strength in most cases. I tell people to take their bandages off after all 3 of these operations. I tell people to take their bandages off at 48 hours, return to washing their wounds at day 4, stitches come out at 2 weeks. Return to work is, if I operate on somebody on a Thursday, which I do at London Bridge, I tell them to faire le pont to the weekend, which is what the French do with movable bank holidays. From a Thursday, just bridge it over, take the Friday off, and they'll be back at work on the Monday. So operation on Thursday, bandages off on Saturday, sticky dressing off on Monday in the shower, give it a rinse, put a fresh dressing over it, and I'll see you in 2 weeks' time in the clinic, but go back to work. For all minor operations, I tell them that. For more major operations, it's usually more like 2 weeks before they get their bandages off. So carpal tunnel is good operation. Trigger finger release, most of these are cured by steroid injection. Again, in this big US study, about 80% of patients are cured by single injection over a 3-year follow-up. And of the remainder, the 20%, a second steroid injection will cure a further 50%. So you only need to operate on 10% of patients. and most patients who are coming up for their third injection will actually decide they'd actually rather have an operation. And I'll talk to you about how much easier surgery has become under local anaesthetic at the end of this talk, when I talk about new innovations in local anaesthesia. And then de Quervain's synovitis, again, mostly cured by steroid injection. Surgery is very effective. The main problem with this one is scar hypersensitivity, or actually, because there are two subcompartments, some surgeons will think they've released it, but there's actually a separate subcompartment for the second tendon sheath, and that isn't always present, but actually if you miss it, the patients will get persistent symptoms. Good. Next slide, please, come on.
Just before we move on, Mark, we've had a question. So Chris Id has asked, if a patient or employee has carpal tunnel syndrome, which has arisen as a result of exposure to handheld vibrating tools, what are your feelings about them returning to the same sort of work following successful surgery?
Yeah, I used to do a bit of personal injury claim stuff. There's the vibration white finger. There's a lot of stuff with vibrating tools. They do come and claim personal injury as well, and they're often quite angry about their employer at that stage. They've often made protestations about using this instrument that was upsetting them for a long time before they actually then came to eventually seeing an orthopedic surgeon. If there's causality, and if you feel that the causality is directly related, then there may be workarounds, but clearly if they have an operation to relieve themselves of their carpal tunnel syndrome, they're unlikely to have it coming back, to be honest. But some patients will have a sort of Raynaud's phenomenon in response to the vibration, and that of course wouldn't be made better by carpal tunnel release. If you're using high power vibrating tools, then it'll take you a long time to get back to holding those after carpal tunnel decompression, probably talking about 6 weeks anyway. Patient will probably be unhappy about going back to it anyway. Gloves, protection, if that's already been tried before it's got as bad as coming to surgery, I think you're in a difficult situation, and it might advise that they actually look at retraining or being deployed in a different capacity if possible. I hope that covers it.
Thank you.
Yeah. Okay. Yeah. Next slide then. I might have to come back to it if you've got any further questions on that, Chris. Thumb-based osteoarthritis, really common. You can often see it. You can often, there's my hand looking like a Y-shaped hand between these two metacarpals and my forearm. But I'm old enough now to be able to mimic an old hand. The two metacarpals become parallel, and the thumb starts to hyperextend at the MCP joint, and these two metacarpals become parallel. You get a bump here with a little shoulder coming up, and that's shown on the X-ray. And what happens is that the ligament between the thumb metacarpal and the index metacarpal stretches out, and that metacarpal sitting on the trapezium, which is like a saddle. If you imagine the thumb metacarpal being like a jockey sitting in a saddle on a horse, he's sitting far too far back because the strap holding him on has stretched. And that comes about as a result of years of spreading your hand widely and having weakness in your thenar muscles here. So hand therapists are good. You can basically support it before it gets that bad. You can support it with strapping or even sports tape. You can strengthen the thenar muscles, which will improve the support around the base of the thumb and improve the vectors of forces on that joint. So hand therapists are great at treating early stage wear and tear at the carpal metacarpal joints. And then steroid injections can be good once it starts to get quite bad. Some patients will have quite bad arthritis on their x-rays, but actually minimal symptoms and don't need any treatment. And about 1 in 10 of my patients who come to me with thumb-based arthritis eventually decide to have a trapeziectomy, have the whole bone, have the whole trapezium taken out through a small 2-centimeter incision here, and a plastic one put in instead, together with a ligament reconstruction to reconstruct the ligament between the thumb metacarpal and the index metacarpal, and bind the two together. It doesn't then cause any shortening, so the thumb looks normal. They should be able to get back to that Y shape again, have a lot of hand therapy. It's quite a long struggle recovery. It's 2 weeks in a surgical bandage, followed by 4 weeks in a thermoplastic molded custom-made splint by the hand therapist, and they wean from that and they do thumb exercises and pinch stuff. Quite a nice little test that you can do is you can do with the patient actually. You can compete. You can sort of go. You can compete with them, and you can see how functional their thumbs are. You can get them to do a paper tearing test. So you go 2, 4, and then as you come up to do 8 and 16, it gets more difficult. And you can, when you come to do this, you should be able to see that the angles of the IP joint and the MCP joint are kept the same. And if they're collapsing like this into the swan neck deformity or the boutonniere posture when they're doing that tearing test, or indeed how much they can tear, I think the paper tearing test is a really very simple and nice competitive thing for patients to try against you and see how they fare with that. You don't need a pinch meter or a grip meter to do that. It's a very functional thing. So, yeah, trapeziectomy is a good operation, day case procedure, done under regional or general anaesthetic. And I do that about once a month. Next slide, please, come on. This is a common thing. Adverse neural tension is what the physios call it. Hand surgeons see a lot of this because it presents with problems with pain in the forearm, and really just to run through these 3 different postures: the ulnar glide, the median nerve glide like this, and then the radial nerve glide like this. And stretching the neck to the opposite side makes the symptoms worse, and they can compare with the opposite side. And if they feel that the symptoms are made worse by that, and it's worse on that side, and then that confirms the diagnosis. The median nerve adverse neural tension is the most common one, and it's often in association with carpal tunnel syndrome. There's a lot of chat at the moment about multiple sites within the hand surgery world, about multiple sites of compression. We used to call it double crush syndrome, where patients get some trapping in the neck, but also trapping in the carpal tunnel. Well, now people are talking about a thing called Lacertus syndrome being quite common, which is where the biceps tendon comes down and then spreads into an aponeurosis across the forearm here, and that can press on the median nerve here as well. And that leads to patients having an unsuccessful outcome from carpal tunnel decompression surgery in some cases. And just being aware of those other causes is important. So if somebody presents with carpal tunnel syndrome, you need to really decide whether you think some of it's coming from the neck. Think about MRI scan of the neck, for example, or physiotherapy assessment, and see if you can make them a little bit better with some nerve glide or flossing, as the physios call it. And if you can make some progress with that, then if you're on an improving trajectory, I always tell patients not to have surgery or steroid injections. I don't put anything sharp through somebody's skin if they're getting better. So no needles, no knives for anybody that's getting better, only for people who are staying the same for long periods of time or getting worse. That's a general good rule. Avoiding surgery as you get older as a surgeon is what you realize is important to get, manage expectations appropriately. So there's lots of that about. Physios around town are really busy treating adverse neural tension, getting lots of successful, excellent results from it, and avoiding surgery. So that's all good. Okay, next, yes, it's Wallant. This is my favorite new thing. It's so good that I feel embarrassed that I've spent 30 years doing operations on people and hurting them so much. Local anesthetic stings like mad when you stick it in. This chap, Donald Lalonde, who's written this book called Wide Awake Hand Surgery from Canada, is all over it on LinkedIn and Twitter at the minute, selling this idea. And in the last 5 years, it's been all the rage in hand surgery. I didn't listen to him for about 2 or 3 years, and I'm sorry for that. If you put in 8.4% bicarbonate in a 10-to-1 mixture with xylocaine with adrenaline, so you put the local anesthetic, 10 mils and 1 mil of sodium bicarbonate, 8.4%, it makes it less acidic and it stops it stinging. It not only makes it less painful, it makes it not painful. I couldn't believe it. And if you use it with his described technique to use a 27 gauge flexible needle, and you do exactly as he says, which is basically you pinch the skin first of all until it's a little bit desensitized, then you hold it as a pinch, and then you put the needle vertically through the skin rather than at an angle. It just goes through more easily through the skin like that, through a raised bleb, with gloves obviously, and clean the skin, and make a bleb. You know, everyone knows what a bleb is. It's just a little blob under the skin, and then push the bleb forwards with this flexible needle, so the needle never goes into the area that hasn't got a bleb ahead of it, and the bleb advances like that. The patients are saying to me, "It's not hurting at all, doctor." It's amazing. So that's really good. So not only is it less painful putting it in, you can put lots of it in, and then if you leave it for half an hour, which you must do, because then the adrenaline starts to work, you don't need a tourniquet. Now, the local anesthetic works in 10 minutes, and it works even quicker with sodium bicarbonate because it seems to be more effective in a more alkaline environment, but they can't sell it like that because it's not stable. So they have to keep it fairly acidic. So not a secret anymore, brilliant solution. You can put a load of this stuff in, and then when you wait half an hour, it becomes exsanguinated. You don't need a tourniquet. You can operate, there's very little bleeding. And by that time, all of that bleb has diffused. So you're not operating through a swamp of water. It's just anesthetized. It doesn't bleed. It hasn't hurt the patient. And it's just wonderful. And the next part of wide awake local anesthesia, no tourniquet surgery, or well-end surgery as it's called, is that Donald Lalonde is suggesting that surgeons aren't in full gown, just in scrubs, so not in full gown, just with gloves. Patients clothed, so that's her in a t-shirt, or a shirt where they can actually easily get it off over the bandages that you put on at the end. And they can come in from the office, have an operation, and go back to the office. And my patients are really shocked if I say to them, you have to come into London Bridge, you have to change into a gown, you'll be in hospital for 4 hours, you'll be on the ward, you walk down to a formal operating theatre environment, there's a whole lot of draping, there's 6 people there looking after you, go through the recovery area where people are throwing up, and then you have to stay on the ward for 2 hours because that's protocol, and then you, so no, they want to come in and have their small little lesion excised from their hand, or their K-wire taken out from their hand, or a small Dupuytren's procedure, or a trigger finger release. They can now come in and have a small procedure done, and we're just getting 120 Old Broad Street rekitted. We've got some nice operating theatres there for this. It'll be much cheaper, and I'm already doing some of these in 31 Old Broad Street, but we're just about to have a better operating theatre and onboard and some better kit. So I think this is a massive breakthrough. It's changed it very much for the better. Patients really are cheerful like that, having surgery. The other thing I'm thinking about at the moment is having if they're freaking out in the environment, we might even get them a virtual reality headset to take them into some nice place and walk around a park or something with a virtual reality headset on. But yeah, it's all getting so nice now. Having an operation, a minor operation, can be so much more comfortable than it used to be. So that's brilliant. And then the other thing that's new that I'd like to tell you about, next slide, please, come on, is the massive way in which my practice has changed since lockdown. I now do lots of video consults, and they're perfect for when I've seen the patient and examined them. I can then give them the results, screen share with them, and they don't need to come in to get their results. And then you can decide to have an operation or whatever else next steps planning can be done at that. Patients can email their concerns. They can send through photographs if they think they've got an infection after the surgery, and I often reassure them that they don't. Sometimes they do have an infection. You can respond quickly by email. I just think it's so much better for patients. But the downside for surgeons, of course, is that actually that means probably an hour to 2 hours of emailing a day. And across the world, that seems to be the way now. We went to the International Hand Society meeting last June, which was in London for the first time. And people talked about how they work around the world. And one of the themes that comes up is that basically, since COVID, people are working like this, and they are doing lots more emails than they ever did before. But it means that we're very much more sort of approachable with our patients. And if you're feeling miserable about the number of emails you have to do, I think it's the same for everyone. So that's a little run through. I think that's all I wanted to talk about. Next slide is a summary of all the things I've talked about today. Yeah, and that's who we are. And that just about leaves us a bit of time for questions, I think.
Thank you, Mark, for that excellent run through and those talk and providing kind of an update regards to what's new within your practice and how it's different since COVID, and obviously the new procedures that you're performing at 120 Old Broad Street, or will be hopefully performing at 120 Old Broad Street. Did anybody have any questions for Ms. Phillips? Oh, Rachel does, so she's got a hand up. Oh, we've got 2 hands up. But Rachel, you're first.
Okay, first of all, thank you so much. That was really interesting, and you know, we see so many upper limb problems and hand and wrist problems, and everything you say about, you know, people who are exercising and yoga and Pilates and all these things, which we all know are very good for you, but we see so many people with injuries. I'd also like to say that ironically, the physio I saw this morning had just been snowboarding and had been knocked into by a skier who, as a result of which he dislocated his shoulder. So kind of
Yeah.
sad ironies there. I
There's
did
lots
want to
of
ask, however, when you we warn patients that, you know, if they've got whatever condition that they may benefit by an injection, what is the limit for the number of injections? Is there a limit? I've always thought that there was, but I don't know if it changed over the years.
I'm really glad you asked me that, Rachel, because there isn't really a limit. Generally, in that American study, what happened is that you get a law of diminishing returns. So it seems that you got 80% success with the first injection. Of the remainder, only 50% success with the second injection, and with the third injection, only usually about 30% success. And so patients notice an attrition of benefit, because you then find out who the refractory cases are. Most patients are choosing they don't want to have the third injection because actually it's seemingly pointless. Depends on how long their response has been. If it's been a really good response for 5 years, and then they might want to have a second one. But if it's only been 3 weeks, then they wouldn't want a second injection. So that's where that is sort of come from, as a culture of 2 to 3, and then have an operation. The other thing is based around tendon rupture. The common rupture ones are biceps, Achilles tendon, and extensor pollicis longus to the wrist. Those do tend to rupture, but all the others are really robust. You can have, and I've got patients now who are physicians who have inherited from me in Winspur, who've had 10 injections over the last 20 years into the same flexor tendon that keeps on triggering, and they don't want to have an operation. And that seems completely safe. The infection risk is like 1 in 10,000 injections. So it's probably, I've seen one in my career of a flexor sheath infection, but you know, I think it's very safe. Steroid injections can be done by pretty much everybody, because actually in that American study it was done by 200 different hospitals and thousands of different people, and it seems the results are pretty consistent no matter who does them. So no, there is no absolute limit to it, but it's usually people find they get fed up after 2 or 3 if it hasn't cured the problem.
Okay, thank you.
And you get skin thinning sometimes and depigmentation, and that sometimes causes people cosmetic concern, but generally comes back to normal after a few years.
Right. Okay. Thank you.
Shamini's got a question as well. She has a raised hand.
Yes,
Hi,
thank
Shamini.
you. That was a really good presentation. I deal with city office workers, and just wondering, when you talked about that slide about de Quervain's trigger finger and carpal tunnel release, and you said post-operatively, so if they were to have procedures, you recommend sort of going to work in the next couple of days. We often advise a reduced workload for a couple of weeks just to reduce repetitive movements of the hands, etc. Do you find, I mean, those who don't have that reduction in workload, is there an impact, you know, post-op, say if we take one condition, carpal tunnel, do they need to take precautions with repetitive work?
I'm not sure. I think people vary a lot, as you know, and some people are self-employed and say, you can't stop me working, doctor, I'm going to have my operation on Thursday, and then we'll fly to Amsterdam on Friday, and I'll be, you know, in the office and I'll be on my phone. And there are some people like that. I even had a very naughty GP who went horse riding for 2 weeks after her bilateral carpal tunnel decompression, busted a whole lot of stitches, had a very thick scar with some keloid around it, and she was absolutely fine. But when I saw her in clinic 2 weeks later, 50% of the stitches had broken out. There was a lot of callus around it, but she was fine. So she was like a test case of the most poorly compliant patient, and what happens if you're really violent to your wounds. And generally, I think you can be quite robust with people. I think it's good to use your hands. I think people over frightened can often be worse than patients who are too robust with them. Whilst it's cautious to tell somebody you might need 2 weeks off for this, or you might have to be careful because it'll be painful and take painkillers. And actually, you know, people will see that they'll go back at day 4 or day 5, and then it's quite sore, and they've done too much. They need to check back a little bit and say, hang on, that was a bit too much for me. And that's when you get little, if somebody's pain's getting worse at that stage, it usually means they've got an infection or their stitches are getting a little bit red and sore. That's the main problem, is that their scar tends to get a bit inflamed. But generally, I like the patients who get back to using their hands normally by the time they see me in clinic. So the ones that come back who have already not second thought about picking up their bag, taking their coat off, shaking my hand and opening the door to the clinic room. I like those patients. The ones that come in like this and are a bit precious with it tend to get a bit stiff. So you've got to find that sweet spot, and people will vary quite a lot. I've also sort of gone off the idea of telling patients how much they should and shouldn't do. If patients feel that they can do a lot more than the doctor tells them they can do, they tend to do it anyway. And if they don't feel ready to do what they've been told to do, they won't do it. So I'm always telling patients to be guided by their own levels of comfort. And actually, if they're not comfortable, I think it's quite a good idea for them to sort of check in with me by email and say, have you got an infection? Show me a picture of your wound. Just make sure that you're okay, and then you're backing off a little bit so you can give it a rest and do some more elevation.
Thanks.
Thank you. Did we have any other further questions? Seems like you've answered everybody's questions. Mark?
I'm sorry, I've been talking rather quickly, but I felt as if I had to get quite a lot to get through. But there's going to be a recording too, so people can sort of slow it down and see if I speak more slowly.
No, thank you very much. As Mark just alluded to, there is the recording, so if anybody does want to view back, feel free to watch it. I also will send you Mr. Phillips's details, so if you do have any further questions or you would like to refer your patients, please do feel free to obviously contact directly. But yeah, thank you all for attending, and thank you, Mr. Phillips, for today's session. Really appreciate it. And yeah, hope you all have a great afternoon as well.
Take care. Thanks a lot. Bye now. Bye.